my first question is to Matthew. Matthew, you have a show called Health in 200 that I follow almost every week now. You guys have an episode about what's going on with investments and where the money is exciting for digital health right now. And we're wondering, some of our audience are asking, what kind of investments are you expecting to see more of after COVID-19? And, reflecting on the global implications, both in like the US and what you'd expect in an area like the Middle East investment landscape.
Well, I'd say quickly that the obvious thing to say is to look at what's going on in the public markets, or the quasi-public market that Ali's in, because he raised a whole lot more than the average IPO in the US has raised. But there aren't that many companies public, but the ones that are, the two most notable ones here are Livongo, which is doing chronic care management at home, and Teladoc, which is doing remote care, both direct for employers, but also, working, and American Well, which raised a ton of money yesterday, didn't get IPO, but same sort of thing. They've grown very rapidly. So what's going on there? This is typical work from home. My daughter has showed up on this demanding I pour her some drink, run away from people, cocoa, and then run away. Oh, you're taking it. Oh, she's keeping most of the ball. Then you can run away if we'll take that. So I think the answer to your question is people are starting to see how do we do that automation part, how do we do that remote care part. The other part of healthcare, and there's been a lot of money invested in this, is how can you make the current system, the current hospitals and doctors and drug companies work more effectively and more efficiently. And so a couple of the companies that went public last year, Health Catalyst and Phreesia, are both in that bucket. Health Catalyst does analytics. Phreesia does kind of check-in for the front office of a primary care doctor. And there's a lot of stuff that's been poorly done in terms of, across the board in healthcare. And we're seeing people use AI, within hospitals. Companies like Qventus are using it for things like, managing flow in emergency rooms and operating rooms and that kind of stuff. So there's a lot of places where modern technology can come and improve the current healthcare system. But I think the most interesting stuff is where can we start building for that greenfield in the future? And I think that's kind of where, so Babylon's clearly in that space. Teladoc, Ali and me have had a private conversation about them. They're an interesting company, but they're clearly in that space as well. American Well too. And then a lot of companies are trying to figure out how do you do what Ali's talked about, which is to extend the ability of technology and, in some cases, lower cost clinical staff to do what was done previously by more expensive clinical staff. And by the way, this is a very particular American problem, because if you look at the data about why this American healthcare costs so much more than everybody else's, it's because the prices we pay for everything, including clinical staff, are much higher than they are because they're not controlled by the government. They're controlled by the healthcare system. Lucky healthcare system.
Well, we actually got a follow-up on that. How do you see both adoption and government regulations changing with that? Do you see any real changes in government regulations so far when it comes to telehealth? In
the US, there's already been significant change in government regulation. When COVID started, there are a lot of parochial problems including things like you can't practice across state lines. So a doctor in New York can't see one in California. A lot of that got taken out as a temporary measure, but I don't think it'll ever come back. By the way, in the UK, you may not know this, Ali, income tax was brought in, and I'm sure it doesn't impact you, but income tax was brought in the UK in 1915 for the war as a temporary measure. Hasn't quite gone away, right? So sometimes temporary measures stay around. The other thing is so a lot of this stuff around, payment was extended for the Medicare program, the wide area. The bigger question, so regulations change, payments change a little bit. The bigger question that you're going to see in the US in particular, it's a very strange system. The Americans cross-subsidize general provision of healthcare by allowing providers to charge very high fees for procedures, for surgery, primarily surgery and stuff like that, which is why American specialists get paid so much more than they do anywhere else in the world. It's become apparent, if you say, because of COVID, we can't do knee replacements or hip operations or heart surgery, whatever, the income of the surgeons and the income of the hospitals that are the hotels for those surgeons collapsed, right? And it becomes clear that those hospitals are all losing money because they can't cross-subsidize to the regular care of people with pneumonia, COVID, whatever, from the lack of surgery. So some people have been talking, I've been talking about this for years. My colleague Ian Morrison wrote a piece about this. George Halverson, previous CEO of Kaiser, wrote a piece on the healthcare blog about this week. How do you fix that? Now, that's back to the big structural problem I talked about before, which is that the people who are doing that, the surgeons doing that surgery, whether it's necessary or unnecessary, and the hospitals that are, hosting it and making money off all the procedure, off all the stuff that goes around it, aren't very interested in getting away from that model. They'd rather just go back to business as usual. But it clearly, as a system-wide thing, makes no sense to pay Americans that way. And we're going to have to go to some kind of global budget, pay for outcomes that is, where some other countries like the UK and to some extent Germany and elsewhere are going to. And or we're going to have to add in probably what you see in Asia, and I know it's much more about this than I do, but Asia, at least, which is sort of cash-based payments for simple stuff.
That's very interesting. Also seeing the other perspective of how healthcare is reacting to it, not just the digital health community.